Bismillahirrahmanirrahim. So let's start the breast contouring. I put always the sign of AMSTRO because this is the society we created in our region and it's very important for all of you to join. I would request you to all go to the, you can have the microphone. You all have to go to the website www.amstro.org. All of you register for the meeting is in February. It's virtual or in person. If you come in person is better because radiotherapy leadership from all over the world is coming there. You have an opportunity to interact with them if you want. If you cannot, at least you can attend by virtual and be the member. So register for membership because there was a breast a talk webinar 2 days back by the two leading doctor, but it would not reach to you if you're not member. So so please take the membership and also the registration for the meeting, regardless, and it's free of cost, so it doesn't cost you anything. So you will take when we in the end, everyone in the room should have the membership before you go. Okay, it's very few the information you need to submit. amstro.org, O-R-G. So write down www.amstro.org and you'll find it. Then there are options of membership and option of registration. Do both. Okay, so we're going to talk about this. So these are our learning objective. I don't want to spend my time on it. Let's go to the breast volume. So there is a new concept come into the market. It actually not new, but for our region it is new. We call partial breast irradiation. So when we treat the entire breast, this is called breast treatment. But when it comes to the only part of the breast, then it will be partial breast irradiation. So I didn't have that. I didn't give you another separate talk which I did in Riyadh. So partial breast irradiation means when the people did the study, they find 86% of the failure happened within 1 centimeter of where the tumor bed is. So we ask surgeon to put the clips, so it will mark. You draw the clips or surgical changes or seroma, and then give 1 centimeter margin for CTV and crop off from the skin of the breast, which I'll show you during the volume, and also crop off from pectoralis major muscle. Then give 5 millimeter PTV margin. Now you can give more than 1 centimeter, 1.5 centimeter margin if you're not happy with your setup error, you're not doing cone beam CT, you're not doing DIBH, and PTV can go from 5 millimeter to 10 millimeter, whichever. It can be your own center choice. But any patient who is T1 and up to 3 centimeter tumor, who's 40 year or older, does have grade 1, grade 2 disease, does not have extensive DCIS, does not have lymphovascular space invasion positive, with the good feature like ER or PR positive, HER2 negative, those patient, luminal A type patient, I don't think we should treat anyone except PBI. So PBI, I use the word PBI, partial breast irradiation, specifically for a reason. Then I will talk to you accelerated partial breast irradiation. So partial breast irradiation, we all know about START-B trial from UK, 40 gray and 15 fraction, moderate hypofractionation, everybody know. This was compared with partial breast UK low import trial. So what they did at this type of patient, which I just mentioned to you, they draw the volume to tumor bed and they give the same dose and they compare with the full breast. When they compare that, they find that partial breast treatment and full breast treatment have same outcome. But can anyone tell me what would be the difference then? Because you're treating very small volume, toxicity is different. And you will one time, if you treat someone partial breast irradiation, it will be very difficult for you to treat the whole breast. Because the DVHs, when you look for the heart, for the lung, we feel so happy. The planner is happy, patient is happy. Because I will talk to you about APBI, which is next step. Yeah, so when the APBI means accelerated partial breast irradiation, means when you give larger doses, you get UK low import trial, give moderate hypofractionation 15 sessions, that did not cut down the time. It just actually cut down the volume. But with the partial breast irradiation or accelerated partial breast irradiation, we did the shorter time, 5 sessions of treatment. If you look into fast forward trial, which people are using now, 26 gray in 5 fractions, they're treating the whole breast. But if you treat the same dose or similar dose to small volume, how easy it will be. So that is what I'm going to talk to you. So, so the now we know the standard doses are 50 grain 25 fraction. We give boost to 10 grain 5 fraction or 16 grain 8 fractions. Sequential boost we call it. Then something called moderate hypofractionation, 40 grain 15 fraction. Start B trial. We treat the whole breast and we give the boost 10 grain 5 fraction or 16, whichever boost you can give sequential. Then something other come is also SIB boost. While we are treating the whole breast again 14, 15, or even UK high import trial, they treated 36 grain 15 fraction. In that case, what they did actually boost the volume to 48 grain 15 fraction. So SIB simultaneous integrated boost. With this, we are going towards that shorter the treatment and intensifying the treatment. What it tell, the learning point, the main point first I want to tell you is when they treated the partial breast irradiation or they did SIB boost or they did sequential boost, what does it tell you? What is your main target? Your main target is not the entire breast. Your main target is tumor bed plus margin. Okay, I'm saying this for a reason because when it comes to your therapist, you can sometimes come into some dilemma. It will help you. So in keep in your mind, your main target is tumor bed plus margin. Okay, secondary target can be the rest of the breast or even organ at risk, depending on what you're using. If you use APBI, the rest of the normal breast will be an organ at risk. Okay, so if this is clear, I will move forward. I will not move forward if you didn't understand this point. Your main target is tumor bed plus margin. Understood, everyone? Okay. So with this now, I'm not saying that you start treating only APBI and because it's only limited to some selected patient, but in future, maybe few years from now, you will be treating, and then you'll remember what we discussed. Okay, that's we are going that direction because UK import high trial. What they did, they cut down the whole breast dose and still find the same result as 14, 15, and hypo SIB boost where 40 or 40 get a 15 fraction used. I have a feeling they will come in the end if you treat the tumor plus tumor margin and the node, and you're fine. But this is my assumption. So one of the very important studies which was used for APBI is 30 gray in 5 fraction Florence study, Italian study. 10-year results are there. People were treated by the tumor bed plus margin, alternate days, every other days, 30 gray in 5 fraction. However, the one who did the study switched to 5 consecutive days, but not using the full dose to this. So what she's doing 30 gray is still to the CTV, but PTV she cut down the dose to 27 gray, and she's doing 5 sessions of treatment. So consecutive 5 can come, and I'll tell you about another study which is done by my resident in Canada, and he actually come up with 27 gray in 5 fraction. It's called Excel trial. It's Canadian trial, phase 2 randomized trial. He was the supervisor of one of Dr. Abbasi's student, Dr. Shahri Shabrar. So Harvey Kwan, Dr. Abbasi, he did this study. So you can use 27 grain in 5 fraction consecutive days to partial breast volume to the selected patient. I say Florence study because it's 10-year data, phase 3 randomized multi-institutional, but it has its own challenges which we can fix. We can do that. So what we do is that we do CTVs, 3D growth. What they advise to draw they ask surgeon to put 4 clips. Yes, please. Yes, yes. Yeah. Can we move it? Who's the technical person here? Just take my face to the because anyway I'm live here. Is anybody attending online as well or no? If nobody online, then no need me to be on camera. I'm here in front of you. I think you don't need camera. That's I think, but ask the other people. Okay, so what they did actually in that study, they asked surgeons to put 4 clips, top, bottom, right, and left. Okay, you would not get this situation all the time, but you get maybe even one clip is good enough. I'd be happy. And the seroma or surgical changes, that would be your GTV lumpectomy, and then you grow CTV from there 1 centimeter and half a centimeter for PTV. So they did that in this study, and then what they did, they draw the 4 clip, and then with 4 clip, then they grow 1 centimeter for the CTV. Okay, so that's what the volume. So it looked like that. If you look like this one, so when I told you that main target is seroma or tumor bed, there's another main thing I have to tell you. Once you finish, then I will tell you. First, take the picture of this one. There's one main thing you already know. Second main thing you need to know, also must in the breast cancer treatment. Okay, so second thing is skin as a toxicity organ. So skin is organ at risk. You must have to shave off from the skin at least 5 millimeter. But tell me, if the tumor is sitting at the skin, what would you do? Yes. Would you do partial breast irradiation or no? Very good answer. You smart guys, I tried trick but didn't work. So yes, so if you cannot do safely APBI, it's a large dose per fraction, then switch to moderate hypofractionation or standard, because they are equivalent. It didn't say that they are one is inferior, one is better. So 5 millimeter from the skin, and if you look at another dotted line, pectoralis major muscle, where the breast is not going beyond, you don't need to go your CTV up beyond that, because when you give lumpectomy GTV, 1 centimeter grow, it may grow over the skin, it may grow in the lung, it may grow over the pectoralis major muscle, but the breast limitation for CTV is anterior surface of pectoralis major muscle and 5 millimeter under the skin. So you shave those off, okay, and then you grow PTV and PTV valve. Why we learn skin is so important. Skin is organ at risk for breast cancer, very important one, but it's so attached that it's difficult to spare. However, you need to know that you don't need to give the hot spot or high dose there, and if you can protect, you should protect, because there is a build-up region. When the photon strike the skin, it does not deposit those all there. If physics can tell us. So then it take the 3 millimeters of build-up time, and the distance. But if you draw 5 millimeter inside, then the dose will go a little bit in, and your skin will get 80 to 90% of the dose. But skin, you try not to give 100% of the dose or more than 100% of dose. If it is chest wall mastectomy patient, that's a different story. Skin is your target. So you want to give more skin dose and you put the bolus on it. Okay? And even try to you cover the built up region even. So this picture everybody understood? Well? Yeah. So in the Florence study, they give 1.5 centimeter margin for CTV. In some other study, they give 1 centimeter. So I would leave it up to you. You can take somewhere from 1 to 1.5 centimeter. In this picture, because the picture they publish is with 1.5 centimeter, my practice is I take 1 centimeter. And then 5 millimeter for the margin. They give the margin PTV 10 millimeter. So to me, it's a little bit bigger, but if you're not sure about your setup error, if you're not sure about cone beam CT, then better to follow these distance. Otherwise, I follow 1 centimeter for CTV and 5 millimeter for PTV. Okay, clear up to here? Up to here. Main target, main organ at risk, because when you do APBI, it is very easy to spare the lung and heart. But only thing that you need to worry about is the skin. So if you're doing APBI, if you draw a target correctly, if you spare the skin, you're good. You cannot do wrong. Okay? Where we learn this, skin is so important. When the new brachy equipment mammocyte come, when they put the mammocyte, it was rounded and give rounded to isodose. So those rounded isodose was going up onto the skin, and they get skin fibrosis. Because of that, this equipment is not more anymore used. They come up a new applicator called Savvy. They try to compensate, but damage was done. So then people don't want to go for that brachy. So we learn from there. Protect the skin, target the tumor bed, you're okay for breast cancer. Lymph node is a separate story. I didn't talk about lymph node. So this Excel study I mentioned that Harvey Kwan have done from Canada. He did free breathing. He did not do DIBH. Some people say better to do DIBH when you do APBI or you're doing left side. So he did, and then he draw the visible seroma and surgical cavity. And if there is a clip, it is. He was happy as well. But Florence study asked for the clip. Here he allow, if you don't have clip, take the surgical changes in seroma, but not to be too far after surgery because seroma should slowly resorb. So you don't have to be go after like 4 or 5 months later you're doing APBI will not be the best idea because seroma resorb. Okay, fine up to here. Then this was Excel study. He did cone beam CT on daily setup. For the setup error, he was doing cone beam CT. Okay, and he was checking them regular basis. Now we come to the breast. So we know the partial breast. Now the advantage of partial breast, when you know how to draw the partial breast, you know how to draw the boost volume. Okay, so partial breast and boost volume is same. Okay, so now I will talk about only breast because we did cover the boost volume, we did cover the partial breast irradiation. So that's so there are three different common one which people use. One is RTOG Atlas for breast. If you guys don't have, I can share. I have them. The other one is Estro guideline, which they publish in Green Journal. I can share that. There's one TROD guideline where they look into the both Estro and Astro and find what is common for the nodal radiation, nodal volume. The best one is Estro or TROD. For the chest wall or breast, it is better is RTOG. I have them all. I can share with one of you, and then you share among yourself. Okay, all three of them I'll give you. And I have even the protocol of first volume based study, RTOG 1005. I was the co-investigator on that one, so I have that. That's also, that is for SIB boost they use. We will come to that as well. Okay, so I share with you all those, and then you guys will learn. Now here what we do, the most common I used was RTOG because we were doing RTOG studies, so we have to follow the atlas. There are some weaknesses in atlas, I will tell you as we go along. So few things you need to learn. So the few things you learn is pectoralis major. We just mentioned that pectoralis major just anterior to the rib cage and intercostal muscle. Rib cage, intercostal muscle. So pectoralis major and rib cage should be out of our volume for CTV. Then large vein can guide us where the borders can go. The clavicle and external notch can help us as well, and the midline as much as also from the lateral axillary fold area. Okay, so we have four boundaries, right? We have four boundaries. So top boundary, where anyone volunteer and tell me where they put their highest volume for the breast, superior volume. Where? Okay, okay. Yeah. Okay. Okay, very good answer. So medial lower end of clavicle. Okay, below that I start drawing that. Very good answer. Now where is the lower end? Okay. Okay. So 2 centimeter below was the field based. And field based was, if we are doing volume based, that would not apply. Because field, think about field is 50% isodose, not 95%. When you give the volume, you ask to cover 90-95%, right? So if you think about old days, those guys were smart. They put 2 centimeter for a reason, because there is beam divergence. There will be 50% isodose, then to reach to 80% will be different. I only draw up to the breast. Where the last slice of the breast gone, I'm gone as well. So breast CTV gone. Then PTV will come automatically, when you grow the PTV. Okay, so a superior border we know, inferior border we know already. Where is medial border? Midline. Midline was the field. External edge. Okay. You all know, by the way, not much to talk about because you all know. So medial end is the lateral edge of the sternum or external costal junction. Okay, because midline also correct. When we do field base, then we put the field on midline. And if any field go beyond midline, they were minus. They do minus. Even if you miss the scar, there's no need to go that far because it will harm more by heart and lung dose and contralateral breast and not gain much. Okay. So here are the borders. What you guys just say. Lateral border. Lateral border, I keep it variable. There is a vessel, lateral, thoracic vessel, have a branch there. If you can see that vessel, you just have to be medial or inside of that vessel. If you don't see the vessel, I see where the breast fold is falling, where the glandular tissue is. It is not mid-axillary line. Again, mid axillary fold line was when we do the field. Okay, and latissimus dorsi is the most posterior. It should not be in many cases, but if someone is fat or have breast shape different, then if you cannot go beyond latissimus dorsi, that means you're not correct. Okay, so superior border, inferior border, medial border, lateral border, anterior border, 5 millimeter under the skin we discussed already. Okay, posterior border, plexus major, major muscle, anterior surface. Done. Okay, that's easy. Then we come here. Now these are some principles. We suggest to do the CT simulation slices 3 millimeter or less. 5 millimeter you can miss sometime. And I do SBRT in the breast, and I don't allow more than 3 millimeter. 3 millimeter is our standard. Anyway, but everybody have to work for their own. So this one we just talk about, right? Where this go? So it's confirmed from the. There is a one problem here. What we talk is not here. It's different. Rest all is same, huh? Yes. So they draw skin, but it's very old atlas. The European they didn't draw. They just in Riyadh they were criticizing me why you are presenting such an old atlases, but there's nobody else coming up with the good atlas. And I asked IAEA, we just finished the prostate atlas and auto contouring. If that project will publish inshallah in some short time, we finished. We put the atlas pictures and everything for prostate. I suggested after the UAE, the Saudi Arabia meeting, that how about we do for the breast as well, because it's too old and it has some weaknesses. She said we are going too fast. RTOG will not be happy with us, because we're taking over things in IAEA. Okay, so rest all is fine. So you all agree the chest wall is similar except that skin is the target. Okay. Now how look like? Just see here. Do you agree fully? I have a little bit of objection here. Tell me what would be the objection. Anyone guess? We said guess what? Which one you dislike much? Medial, okay. Okay, medial and okay. Yes. Yes, mashallah, You are all awake, right, after lunch. Or nobody is missing things. All things you're picking. Very good. So here, I will take it in. But because if you crop by 5 millimeter, then it may go. But anyway, I'll take this. 5 millimeter cropping. This is hand drawing. This is not cropping. The first patient I treated on RTOG 1005, which is the first volume-based study, I took whole day to draw the volume. But I learned something. I'll tell you the trick today. It take me very short time now to draw. Because that day I promised myself, how can I enroll patient on this study? If I enroll, then the whole day will go, because I was doing manual drawing, everything manual. Come out of manual. Come out. Use the tools you have. Then lateral, literally from here I will be here, because I see fold here. This is axillary. This is axilla. We're going into axilla. So I will be a little bit more medial, especially if it is marked better, because after pectoralis major muscle, and you need to start thinking about where is your lateral end. Don't go too far beyond that. Okay, because then we start going into axilla. Do we need? We don't need. Okay, that's the so you pick up all those problem in this drawing, but that's fine. That's fine. We can do that. That's just for a guide. You need to learn. Here they start drawing seroma. Okay, the most difficult boost location is medial. Medial, because other contralateral breast tissue is thin. Look at the tissue here, thin, and then it go through the lung, full heart or whatever. So medial is the problem. When you treat the medial side boost is difficult, not easy. Okay, anyway, there is a clip. Some good surgeon did that. And here, see the glandular tissue is turning here. So there's no problem going here as well. And you see the fold is coming here. So you can, if you go here, I'll be okay. If you go here, I'll be okay. Because, there are no sometimes hard and fast rule that it be like 100%. You need to accept some variability. And by inter-observer variability, even if you give me a volume that I come in the morning and give me same person volume in the evening, it will be different. If I fight with my wife and I am good mood, then it's different volume, right? So everything we are impacted by this. So here is this latissimus muscle. It come to the near the almost the end. I would not come that far. I will stop here. So there's a room to improve RTOG. Agree? I would talk to the manager, again IAEA, that I proposed. She said, what do you want? You'll put us fight with the RTOG because if already you did prostate, now you want to do the breast. So, but there is a need, right? We can improve, we can do better. Why we have to stick to the old one? Okay, then anybody, any disagreement, tell me. I want to save your time, so I'm going faster, but we know where this is mid-axillary wire. This was 50% isodose line. Please don't go by that anymore. If you're doing field-based, yes. If you're not doing field-based, then you need to do the wall. If possible, I know there's a resource issue, there are equipment issues, but if possible, switch to volume-based. You will enjoy and you will learn a lot. And you will see how you are doing past. And then if you do a volume and put the field and look into it, what are we doing? It's different. Now to say that which one is correct, which was not, difficult to say. Even in Canada where I practice, they have so many breast cases, they do field-based. They don't have time. I say we cannot, period. But where I'm working in UAE, this is the first place in my life I'm working where shortage is patient. Not machine, not staff. We are fully staffed, we treat almost half or even less. We have 2 machines and we treat 20, 25 patients a day. But I also gained something from there, that if you're not in busy center, you can do better job. Also, you need to learn. You cannot just keep working like a machine. So when you get to time to break, to think, and when you think, you start learning. So thinking is the first step for the learning. So it's not a bad idea that you are in sometime not so busy, and it's also not a bad idea to be busy because then you gain the experience. Okay, like see, this is no objection, I think. Coronal. If anywhere you want to stop me, stop me. Then sagittal. Okay, I usually look into those 3 views. Put the 3 views up. Okay, any questions so far now? No? So I tell you, Radcom, it's built for randomized trial because they're doing photon versus proton. So what they have to do, they have to cover everything because whatever come in, treated, not come in, not treated. Photon is different, right? So the Dr. Atif Jalis Khan was Nadeem Parvez, who was here. He's a student in Aga Khan. He's now Memorial Sloan Kettering, head of the department in radiation oncology. He's the PI of B51 study. Someone talking to me, I'm doing a chairing session, B51. I said, no worries about it. I talked to Atif Khan myself. The way paper published, that's not the way practice is happening. He himself not doing that. So it is very important that I can give those messages because I chair a session for him when he was the speaker. So he's very helpful guy. You guys can be connected with him. He always, because he's origin from our region, and he spare time even though he's so busy, but he spare time we ask for webinar or anything, he does. Very, very good guy. So from him I learned, I pass on. So Radcom, he built the Radcom Atlas for the proton reason. So not to be misled by that. So look at Radcom, look at the volume. Because you don't want to miss anything, right? So he go that far. Do we treat this far? No. Okay, so look, this is the way. But you have to draw everything. You have to draw everything, target or organ at risk. Because whatever missed is missed, It's taken as can hit. Okay, look at this. Look at here. Can you cover with the photo? So, one of my resident, and I felt it bad, therefore I'm just saying to you guys, one of my Saudi resident, I trained her in Canada. She was in the course with me in Riyadh. So and therefore I told you that I'm going to show you something extra. So I did not show Radcom. I did not show to the people. Proton, with the proton. Photon, no, you cannot. You can, when we were doing APPA old time, and you can. So what he did, he told me how he draw. He said, I put the field of old time. And in that old time, I draw only target area because proton can do that. Proton will not treat these muscles. But when you do photon, it will. Lung, it will not treat. But in the photon, you will do. So we don't, now when we draw volume, we don't draw like this for photon. Either we do field-based, then we treat. Anyway. So, but he can do beauty of proton. He can treat these, what we were treating in past field, but he can avoid those which we were not be able to avoid. Right? So, anyway, I did not put these slides.
So after I finished the session, I'm her teacher. She stand up, she said, I can do some addition. I said, okay. I said, oh, no, what's you're going to add something? You can learn from anyone, anytime. So then she said, she opened this one from online. I said, you know that anyone present there, do you have anyone from Photon Center, Proton Center? They said, no. That's okay. This was built for Proton Center. She doesn't know that Atif Khan is my friend, my relative actually. I don't want to say much, but he's my relative and my friend. So I told, do you know Atif Khan? She said, yeah, he's the one who built the Radcom. I said, yeah. So I talked to him. And if you want to talk to him, talk to him. It's for Proton, not for Photon. He's doing comparative study because we're doing field-based. So it's fine. He will show Proton is better, right? With this coverage, he will show better. So they have to design a study to be successful. And then, I do paper publish, and when I do a study, what do I want? A positive study. Whatever way, Some people even play here and there a bit to show positive. Some people design the study to show positive, which is also okay. Like if Proton is doing better, that's fine. It is doing better. So anyway, so I have to tell, and that's how I put those slides for you guys, that in case if you think that I'm missing anything, no. And it treat internal memory or something interesting. They do that. They go from supraclav direct to, which makes sense. Supraclav to internal memory. They don't break in between because there's continuous vessel. But when we treat, we give a gap in between. How come? It's the same continuation of the vessel. Some place you thought up to 3 is okay, and you thought above that not okay, and then supraclav need to be treated, then below that not need to be treated. He treated the whole chain. Honestly, when I treat internal memory, I treat the whole chain. Either I don't treat, or when I treat the whole chain. I'm not going to upper 3 because MA20 I was co-investigator, so I know their challenges, what are the issues there. Anyway, so these are he also put the implant patient picture. So what the difference is, like before we were going to the posterior edge of the rib cage, he go anterior, but he did cover, because there are people talking about covering only this area, which is not correct at the moment. We don't have evidence to do that practice. I have seen some failure behind the implant because now we do pre-pectoral implant. Before we were doing under pectoral, so that could be okay. But pre-pectoral means pectoral is sitting behind. If there be any disease behind, and you don't detect them because it's behind the implant, so you're not palpable. So the failure you don't know unless you do MRI. So you need to do the MRI to know where the failure is. So it's very challenging, and we don't do MRI regular, right? We have to live in our world where we are living. Here is the astro. This is also I put up to you guys just because someone objected on me. So if you look at that, astro said the 2 vessel. If you can see the vessel, it's really good. You see this vessel? So not every case I find, but some cases I find. Then you can cut your breast. See, this is a fat lady. You would not know. You may come up to latissimus dorsi muscle because you don't have the boundary. Glandular tissue finish here. But if you have the vessel, you just cut here. Okay? So that's something she brought good. And look at the medial vessel. Okay? So inside those vessel, medial vessel, this one, or lateral vessel, this one, breast tissue is within that. Okay? Now I don't like this one. I will come up to the pectoralis muscle. They liked it. What she think also, I have to correct her. She think it's a breast fold. How would breast fold will look like? When breast is pendulous, it fall on your skin. You see 2 skin on each other. When you see 2 skin on each other, then I will take that type of volume. I will not take the fat behind it. But I have to see the skin of the breast and skin of the body. Okay? I don't have the picture. If I would have a picture, I show you, you will not miss. If this pendulous breast sitting on the body chest wall, you don't have to treat the chest wall behind. You have to treat only breast. So when you see 2 skins coming on each other, there you just go inside the breast. And even the posterior part of that breast skin, you can leave it because that's the skin. It's not even body like when you draw. So unfortunately, I don't have a picture. I should have taken few patients, taken one picture and can show you guys. But I will be better in future presentation. I would be better. And also maybe if they agree to draw the atlas, I will do it better. We always try to learn. If I put one picture, it will tell everything what I'm explaining you in a minute. Okay, so they said to remove 3 to 5 millimeter under the skin. 3 millimeter because there is a built-up region for the photon. Up to here, everything is okay? Any problems? None? Sure? Either you understand nothing or you understand everything. Which one? Everything? Okay, let's move. So this is the branch of lateral thoracic vessel. I forget this one was the name, but when I was studying anatomy, I was very good at it, but now you see what, I don't know why we're studying so much anatomy, but there is a use. I'm just joking. There is a name for this one. I cannot recall now, but maybe if it is written in the guidelines, so I will give you the guideline. It would be written the name. Yeah. Okay. Yeah, it is written here, right? Obese patient, they wrote. I saw the obese patient. So number one, okay, okay. Now remember it, but don't ask your teacher this question. He may fail if he don't know. He say, "Why you're asking this?" Okay, you have a question. Yeah.
So sometimes we get that there is a huge seroma. If we want to cover that, then we have to go very lateral, and sometimes it goes to the posterior near to the latissimus dorsi. So then what we should do that?
Okay, so it is allowed for breast to go up to latissimus dorsi. It is, if you need to. Beyond latissimus dorsi, I will ignore. Now, seroma of axilla, I can expect there. But seroma of the breast should not be unless it's in the breast tail area or very lateral part of the breast. But if it is primary surgery seroma, I'll try to include. Because what we were talking also that what is our main target? Main target is tumor bed, seroma, surgical cavity, clips. That we must take. If you miss other part of the breast, I'm fine. And if you go beyond latissimus dorsi, that is my border. I don't go beyond that, whatever. And the other one is I don't go beyond the midline. Even there's a scar, I will leave the scar. I'll not cover the whole scar. So these are two extreme borders. And depending, I just treated a patient just last week. She's a pathologist herself. And her seroma, as you said, tumor was axillary tail, upper outer quadrant. And seroma was in axilla. So there's another addition on almost axilla because breast tail. So and then she was borderline indication for boost. So I talked to her that don't take the boost, your borderline indication. She said no. Even 0.1% benefit, I'll take the boost because she's doctor herself, right? So she asked for the boost, even I did the boost. So one of my colleague have saw my volume, we do peer review. He didn't agree with me. He said this is axillary surgery seroma. I said I did proper investigation about it. I go to surgeon, look into primary tumor and everything. Then I'm doing this. He didn't believe till the end. He said you're treating, this is axillary surgery seroma. So it can happen, but not very often, but can happen. But keep in your mind where your edges are. Okay, is that answer?
Yeah, thank you.
Okay. Any other question anyone have? No? Because we're almost completing our contouring, here is after this talking, then contouring will be easy. And someone will be in trouble. I saw the contour. For me, I will have some objection with the apologies. So there are differences. You can read and find, but okay, it's easier here. CTV, primary, focus, I was saying the same. RTOG, same. RADCOM, same. No different. Proton and photon, they mentioned. Nodal contours, I like Astro, by the way. They're vessel-based. Because, I do a lot of prostate. So prostate lymph node, pelvic lymph node is vessel-based. So I trained one of my colleague who was like my class fellow, but then become my resident later on. He came late in the radiation. So he draw the shape he saw. He don't care about the vessel. So I can only laugh. I told him, this patient have a natural anomaly. His vessel is not the shape that. So if you go by vessel, node should be by vessel, not by the picture you have seen. Picture will be applied to most patients, but some patient it would not apply. So therefore, I like Astro 1 for the nodal delineation. And also, but they are sometimes a bit over generous. So cautious about that. If you see something unusually going, and therefore TROD I will give you as well today. The TROD will help you for that. Okay. Then they did the skin, so good. I like internal memory. When internal memory was treated, because I will give you another paper which published from Korea, where they did randomized trial for internal memory to treat and not to treat. Because the data of benefit of disease-free survival, not overall survival, from MA20, I was co-investigator or any other study, that there is a benefit of treating the vessel lymph nodes. Which lymph node? Supraclav, axilla, internal memory. Which lymph node? We don't have that data. So this is the only randomized trial I saw where they did the internal memory versus not internal memory, and they found the answer. Okay, so central tumor and medial tumor, or if it's N2 plus, was beneficial. But I would share with you that paper. These paper remind me, before we go from here, you all should have those and go and home read, because then the benefit will come. You need to know at a scholar level to make that, in your mind decisions. Then internal memory, and then RADCOM. RADCOM difference is that we draw heart only in RTOG or Astro or Estro, but they do the individual heart. Why? Why they draw LAD in proton? Very easy, right? So now you guys will know. No one can trick you anymore. They say, hey, you're using RADCOM. Say, I know that. We don't have proton, sorry. So this is your answer. Now here is the difference. The Strone, it was Strone, the Canadian guy who took some other people, transatlantic, some from different center, and they said, let's analyze how Estro and the RTOG are different. You can see the NRADCOMP is different. So you see. So I will share you with this one. So Drone, Astro, RTOG, I'll give you. Then I'll give you internal memory or no internal memory. Okay, those. So 4 papers so far we remember. If you want APBI paper, I can share with you APBI paper as well. Okay, then this is Estro look like for the vessels, that how they draw the vessels. And I like Astro more in better, because when I was talking in Riyadh, it was for the breast, not for the node. So I missed to RTOG nodal. I did not include here. Still, I have to improve my presentation. So when I show you nodal, they were missing level 3 lymph node. They were not drawing. See, we know level 1 is below pectoralis minor. Level 2 behind pectoralis minor. And level 3 medial. They dropped to pectoralis minor, they didn't draw the medial. So they missed one level, level 3. Very important. I saw the notes. You guys would have seen the notes. Now the other, an important point, because I'm talking about this, come in my mind, which I must share with you. Interpectoral lymph node. What we call it, rotors or something, yes, no. Don't forget about them. So they don't come in level 1, 2, or 3, but yes. You can draw in level 2, but it's behind the pectoralis minor, they say. It's actually in front of pectoralis minor. So don't forget. When RTOG study PI, I asked him, what about interpectoral lymph node? He said, did we not include? I said, no, because you said go to RTOG Atlas. Okay, so RTOG Atlas not including. He said, oops, it's a problem. Then we assess after doing 1,000 patients. So then, when we assess, so we found that radiation is going there. But it should not be this way. It should be drawn, right? We miss in RTOG 1005. We miss interpectoral lymph node. And I see my eyes, because in UAE, there's advanced cases, interpectoral lymph node, very common. I even boost them. When there's a node-positive disease, I have a theory. This is keep to only this room, not to tell people because I didn't publish. I call it myself 2-treatment or 2-hit theory. So 2-hit theory in my mind, if somewhere you treated with radiation, chemotherapy, and surgery, 3 modality, right? If you must treat at least 2 modality. So I give you an example. Axilla, there's lymph node, and interpectoral, this lymph node, level 3. Because surgeon go up to level 1 or maximum little bit of level 2, okay? So not all of even level 2. If they do that you'll see that 40 lymph nodes or 50 lymph nodes, then it is full level 2. So no need to do. This is harmful to the patient. So if surgeon did the surgery, lymph node remove. So lymph node receive 1 treatment. When you give chemotherapy, you get another treatment. Or if you get not chemotherapy and you did radiation and tangential field and you cover those, so 2 treatment done, right? So 2 hit is done. But if it is supraclav node, there will be no surgery, only chemo. So where is second hit? So I do radiotherapy boost. So I go to the higher dose to that volume. And even if it is a streak left, streak, because remember when tumor bed, after surgery, what they find? They find pocket of response and pocket of no response. So when the chemo effect, it does not finish, clean it all, no. Here and there will be there, so the bed. So I give it a name, which is not common, node bed. You will not find anywhere. I'm just saying this is mine, so don't quote this, not scientific. Scientific is that I should publish this, prove it and publish it, which I didn't do. So I call it node bed is still there, even if node is gone. So try to find an excuse and find a streak or something and draw that as GTV and then grow it for the PTV and I boost it. Because second hit, this is my very important learning after 20 years. You need for breast cancer 2 hit. Okay, 2 hit. Keep in your mind. And now start treating contralateral, supraclav, treating internal memory, gross node with this principle, and very good results. Very, very good result. I'm happy that I can benefit patient big time. Instead of give up, do that. The only thing you need to keep in mind when you're escalating or going up, that the toxicity should not increase. How? You put your constraint same. I keep the same constraint. What is start B constraint? I use the same constraint. As long as it's meeting the constraint, you escalate the dose to tumor. Tumor is your enemy, right? So give enemy more slap, stronger slap. They should not come back again to you, right? Yes, tell me. Any question, anything, or anyone? Up to now, you understand? 2 hit theory is personally for you. Don't quote me anywhere. I cannot defend it, yes. Okay, and the node bed also I haven't heard from anyone. That's my own. So, any question till now? No. Okay, very good question. Depending on what fractionation schedule we use. If I use 15 fraction schedule, you see that when we do concurrent SIB boost, we go to 48 gray. When there was a study, import high trial. Import high went up to 53 gray in 15 fraction, right? Now then import, and that is for microscopic disease, tumor bed, not gross disease, right? But they reach up to there and they said, it did not improve outcome. So there is a ceiling, they said, don't go beyond 48 gray. But one of their arm was 53 gray in 15 fraction. So I have my own formula for that. UK, Christie, I went there for some time. They were using in past radical dose of 51 gray in 15 fraction. Okay? So again, I repeat, 48 it very easily we given in breast tissue without any harm. 53 we given with some more side effect. So you need to come somewhere in between, right? So I would not go 53 probably, but I roughly will take 50 as an average. But if I can get 51 without increasing toxicity, no important critical structure beside it, I go 51 easily. 51 and 15 or 15, 15. It's not going to make much difference. But in breast, for some reason, even 1 gray make difference. Big difference. Because when fast forward 26 and 27 gray, when 0.2 gray one day make difference in toxicity. So therefore, I try to keep to what the data I have. Even though I have some stuff which I said to you, non-database, clinical experience based, which is level 5 evidence, but still, I keep to that. So evidence is 51 in 15 for radical doses. They use in past. If you use 25 gray fraction, I do SIB boost up to 60 gray. And sequential is not good for boosting, because sequentially you have to put through all the doses again through the critical structure. Then your critical structure dose will be high and you may not achieve it. Try to do HIB if you have. If you don't have, you can do sequential. Okay? Any other question? If you don't think loudly, don't ask me. I will not know what am I missing, because I'm missing many things. I just cannot have the complete discussion in short time. Yes.
If we want to give the treatment in fast forward, then we can give the boost to the 60 gray, up to 60 gray.
No, because the ultra hypofractionation is different. I talk about moderate hypofractionation and standard. There is no evidence, but I just learned from Mayo Clinic Professor Sean Park. You can type him. He came to Riyadh with me, become a very good friend. We have lots of good picture and we laugh, and he'll be coming to AMSTRO meeting. So anyone who can come AMSTRO, you'll find the leaders of the world. He said he is boosting because he said Mayo Clinic, many people go from different part of the world and they cannot stay longer. So what he did, he said that I draw the GTV and give little margin around 3 millimeter, and I try to boost 30 gray at least, or a little bit more in Mayo Clinic. Fast forward with fast forward. So rest of the breast, 26 gray in 5 fraction, and the tumor, gross tumor, if it is anywhere, then he treat up to 30 gray in 5 fraction. But he said, this is my personal practice because I have no choice. But I would personally would not treat. Okay, we need to wait because they're treating lymph node with 26 in 5. First, let the lymph node result come. Okay, then we go beyond, right? One step at a time. This thing which I don't do today, I'll do it tomorrow, and I'll laugh at me why I was doing this way. But we need to go by evidence. So I told him it's not evidence. He said, I have no choice. Patient come for example, Bangladesh, someone will travel there. He cannot delay them. So he have to treat. Okay, good answer. Okay. Any other question? None? Okay. Let's move forward. So we need to do the imaging. Minimum is KVMV images. The other one, I like the cone beam CT. Breathing movement, I found in my studies 3 millimeter or less. We think it will be more, it is not more, because see, it is diagonal expansion of the chest wall. It's not one direction. So you feel like if someone is anxious, if patient is anxious, start breathing more, that's different story. But free breathing, don't go more than 3 millimeter margin. And always remember, if the thickness of the chest wall or the target is not changing, whenever photon is strike, then it create the isodose, it will cover. Even during breathing moment, you don't miss anything. You don't miss anything nowadays. But this is very difficult for me to explain to sometimes people don't understand what I'm saying to them. When photon strike on your skin, it create the build-up region of 3 millimeter, create the Dmax, create the dose, okay? If the breast tissue is, for example, 3 centimeter, if 3 centimeter stay 3 centimeter, no matter which cycle of the breathing it is, it will create that isodose. So breast will be covered, okay? So, but what I like is the breast brachy. Because brachytherapy, there's no setup error issue. With this treated, you treat it the same way. I did not have that presentation. This is only for the volume. I have a separate presentation that what type of doses do, what advantage, disadvantage of every, but it's different talk. I'm not scheduled for that. So I'm trying to bring some of it in here. So cone beam CT, DIBH, if you have, is a good idea. I even treating right side with DIBH, and I'm drawing the liver as organ at risk. If you don't, you will see something very interesting. There'll be isodose coming because of lung protected. The moment it touched the liver, it go like this. So you're covering extra liver for no reason. So there are multiple papers coming as well. So at least it draw the dome of liver, and by doing DIBH, if you have facility, it reduces the dose to the liver. So DIBH is not only for left side. Of course, left side is more important cause, but right side as well. And when I do APBI, I do DIBH. The other thing is SGRT, tattoo-less treatment we call it, because we have one tattoo, this is millions of tattoo. So if you have SGRT and you do DIBH, it save a lot of time for patient. It is worth. Contrast may help for the vessels, but depend on the center. So I draw these volumes. You don't have to much worry about that. This you don't need to know much. These are the references I talked to you, which I should share with you. This is the meeting I was talking about. So just take 1 minute by the time we open here, www.amstro.org, few information, membership and registration. So let's see, let's just assume this is a breast patient, and we're going to treat this patient as breast. I turn off the volume being done before. I know that's what's for to save your time. So what I would do to know the breast, in some time anatomy may not tell you the exact ideal, because what is ideal? This is medial end of the clavicle. So if you go down, 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 the breast should start from this slice, right? But this patient have more fat, and it's even higher. It's hard to differentiate, but anatomically it will be here I should start.
Then I will see. I will come back and look into gland. Let's start as a normal person. So you said medial edge here, right? And look how I draw. I come here. Sorry, yes, yeah. Come here, and then I just draw like anterior surface of pectoralis major muscle. My hand may not be so well controlled because I have different mouse. When you come to this edge, start thinking where I'm going to exit, because beyond that is actually the axilla. But here in this case, it's not usual anatomy. You see pectoralis minor in this machine, in this patient. Pectoralis minor is beyond pectoralis major. You see here. So for this patient, and for this patient specifically, otherwise in general, what I would do, I would turn around here. Okay, because you can see that, right? You can see that. Sorry, it's a bit lagging. So, and here I did few click, it didn't work. So I would come around like a little bit rounded, not a straight line, like this. Okay. So if you look, you can come up to here, but I think it's okay to have this breast fold in up to here. But this is an unusual example of pectoralis minor going beyond pectoralis major. Okay, so this will be medial end, this will be lateral end, this is posterior end. Now anterior I go in the air. You see that how far I go to too much in the air. You will see that how easy life will be. So as I told you, when RTOG 1005, I was drawing all the volume by manual. It was never perfect, never correct, and took whole day. So now I draw only two structures. Tumor bed, or lumpectomy GTV I call it, because that's what the RTOG is saying in their study. Lumpectomy GTV I draw, and the breast CTV I draw. Rest all either I crop or I boolean in or I grow, whichever. I use the tools. Okay, we'll come to that. So this will be my top slice. And what I do usually, I want to know how much millimeter thickness the slice is. So see here, how thick the slice is here. 5 millimeter. So that's not. I would favor 3 millimeter, but it's okay. If it is 5 millimeter, you can draw more slices. When it is 2 or 3 millimeter, I draw after 2-3 slice. I draw one slice, because that give you nice conformal volume. Otherwise, it's very jagged. There's no need. Some slices you see things better. Some slices you don't. So I take the slices which I can see, and usually when I draw, I keep myself on the 3D. Sorry, this is the. Oh, now I have to, because I'm trying to move this in here. So you keep seeing what you're doing, right, in 3D dimension. So this is the way I do. So you have another, because sometimes sagittal, if you have, this is 5 millimeter, it means you have 5 millimeter thick image compressed and give you volume averaging. In volume averaging, that's axial slice you may draw, but if you look into sagittal, you will be missing 5 millimeter. So sagittal looking is a good idea, which I always like it. Okay, then I draw one. So 1, 2, 3, for example, here. I took another 3 slices, and then I go there to the muscle. Sorry, it's clicking, sometimes slow. Okay, then anterior muscle, anterior of the muscle, exactly that, and I turn around here. Okay. And I don't give these corners like this. I will make it a little more rounded, but I noticing that when I click multiple time, sometime it clicks, sometime it doesn't. That's okay, because we are doing here for practice. And here again same story. And somewhere, if you think I should do differently, please tell me. Okay, because I want to learn as well. Now you see how the breast tissue is covered here. Okay, and then so let's, for the understanding, yeah, here, see, I will come to that. Let's do one more volume here, and then we jump down, because you don't have to draw exact perfect breast today for this patient, as long as you understand what I'm saying. Okay. Okay. Then let's do the GT lumpectomy. GTV is, you see these two clips. You may have more clips. That may be homeostatic clip. These two clips, surgeon put it for you for the boost. But there is one important trick which I learned from a surgeon. When they cut the tumor, they go into the muscle, because they want clear margin. So
So they want to take the healthy tissue, because when surgeon remove tumor, he remove one tumor plus 1 centimeter healthy. And what we want to treat is the one that removed bed and 1 centimeter more, because the study was shown that most of the microscopic extension of disease was less than 2 centimeter, right? Within 2 centimeter. So 1 centimeter and tumor surgeon removed, and then 1 centimeter you are covering. That's why I'm 1 centimeter, but you can go 1.5 centimeter if you're not sure about surgeon, right? So so we do that, but the surgeon, because we want clear margin to go medial lateral easier for them. Anterior margin is challenging because the skin is a limitation. Posterior margin is challenging because muscle is there. If tumor is deep, they cannot have 1 centimeter. They cannot have. So some surgeon, what they do, they shave a little bit of the muscle just to show us that it's clear margin, even if it is positive margin. If you shave off the muscle and it was up to muscle, it would be clear margin. But the poor guy would be blamed, or girl or guy would be that, why did you do positive margin? So it would not be positive margin because of the muscle. So what they do, they're habitual to go to muscle. Hair is also habitual to go to muscle. But this doesn't mean that I will only rely on these clips, because ideally you should have 4 clips. Medial, lateral, which is there. Anterior, posterior, you don't need posterior hair because on the muscle. But anterior, you don't have the clip. Okay, so I draw it differently. Let's draw the lumpectomy GTV now. CTV, I give you an idea and I go to the inferior and we just create something, but don't worry about it, that how it look like. Now so remember, when I start drawing, I draw the lumpectomy GTV first. Then I draw the CTV, and then I play all the tools. Okay, so let's do lumpectomy GTV. We create another structure here, and new structure. We call it GTV, and you can name it the way you want it. It's just kind of because I was RTOG study person, so then I was taking as, oh sorry, GTV didn't come. Okay, small, okay. So for example, GTV primary. So, and I give it another color because we have different colors already, right? Maybe green, maybe, just fine. Okay. Did create, okay. Then I go there. So, of course, my borders will be in here. Posteriorly, I would be a little bit generous than usual breast, because we know the clip is coming up to here. And then I would turn around and I would take the clinical information into account, and according to that, I'll take the anterior border. If it is only 1 centimeter, I would not go too much beyond. But if it is bigger tumor, then I would go more. Okay, because there's not much surgical changes we see. You know what you see is glandular tissue, very thick glandular. This patient must be young or fat, one or the other. Is she young? Do anyone know the age of this patient? No. Okay. So usually this patient 43. So she is younger patient. That's how her glandular breast. So you would not be able to differentiate here surgical seroma, glandular tissue. Okay, the other thing, if you have any confusion, then you click on the contrast. I find abdominal contrast is very good for breast contouring, not the breast itself. See here. How clear now you can see. Okay. There is another one. I draw the prostate on cerebellum setup. People laugh. I said, yeah, men brain is another prostate, That's what the reason is. So cerebellum or brain. Now here, look at cerebellum, how it look like. So if you want clear plane between two, you go to this. This is the same guy who created Tomo and MR Linac. He told me, you want MRI? I can give you MRI from the CT scan. But you need to play with the contrast. And he played and he showed me things what I want to see. Look how the different it is. Okay, now I will do this one, abdomen. Isn't it better than breast one contrast? I draw an abdomen. So don't ask me those questions, but I do this. Okay, now very clear. You see this is glandular tissue. How clear glandular tissue, right? And this is some surgical changes or fibrosis or scarring. But up to here, this line, all glandular tissue. Anyway, not very important, because when we grow PTV, 3D and everything is covered all. Okay, but it's good to know. Then what I do Control C many times, and then I paste it down. See, where you don't see the clip, there is the challenge come. But here is the clip. So whenever it is clip, it is easier. When no clip, then is a problem.
So here, like I would stop here. Okay. And I do Control V. Okay. So see here. So this clip, and now you can go a little bit posterior here, and then you already is in, and you may modify here not to go that far, but I would want the patient information, clinical information. Based on that, I will keep according to how wide the tumor was. Okay, and then you can bring the crosshair onto this. So you see all level while you're doing this, and start making your habit. Sorry, start making your habit to look into 3D. Why is bothering me? Click, delete. Right click and then cut is where? Which one? Last one? You do that. Oh, okay. The bottom. See, this will keep bothering you, you know. No? Okay, let's do something. Okay, done. Now. Yes. Now when you do this, this one, if you come cross here, again it coming out and then you start doing that. So let's unclick this one. Unclick. Now will be easier. And actually the system is very slow. Maybe it's because we're doing contouring here. So start looking into things on the sagittal as well. You see, it will give you an idea where the clips are going. See here the clips are. By the way, it's a bigger seroma. I would expect a little bit less. Now I want to click on the contouring. This one? Yeah. Okay. Oh, select the structure, yes. GTV. No, not boost, no. Yeah, this is the one. Okay, now that's fine. So you see here this level you need to come at least the last slice. So I did here Control V as well again. Oh, because it's not coming now anymore, because we go out and come back. So it's a little bit, but the newer system are a little bit different. They are easier. When you do upgrade sometime, then it will be. Yes, that's the reason I think, yes, because I used to the 16, but it's fine, you know, that's okay. Okay, so you have an idea, but look at how long the boost. So there must be some of it may be homeostatic clip. The tumor would not be that big. So I would, in this case, what we do, we talk to surgeon and ask them, and you can look into pre-surgery images, like if you have mammogram, if you have CT before. So I look into the location. This long should not be ideally be boost volume or tumor bed. Ideally not that long.
How many slides should we take after the surgical clip?
So a surgical clip is your last slice for lumpectomy GTV, because then you'll grow the CTV and you'll grow the PTV. So the top and bottom both. Now let's interpolate. So I usually interpolate, but this not this way interpolate, you know, because it's only 3 slices I draw. It's every 1 or 2. But it did give you not too bad. It's just because practice, so it's okay. But for the otherwise, I should have clinical detail, I should have surgical detail, and then I make this. Okay, so it didn't turn out so bad. But this is a boost volume. Let's finish the breast CTV and then come back to it. And I will again for this purpose, now I want to move it. So I do it small first and then move it. Look, there is something there which will never let you plan. You know, this one, you will not be able to cover this breast. Let's delete it. Oh, this is the, you have to go to the GTU boost, yes. Now start drawing the breast volume, huh? Wow, this will give us play here for till the evening. Will be keep playing now here, and now bring it here and then delete. Right? Delete is which one? This one delete. Okay, good. Okay, so now we have tumor bed. We drawn somehow. We manage. Now we're going to go to the breast. Let's do this, but unclick first this one. Now I'm learning. I learned this system now. And bring to the breast. Now you click to the breast high CTV and then go back to draw, right? Okay, that's okay. 5 minutes if I can learn this, fine. Okay, so I will. Did you anyone see the lateral thoracic vessel which we were talking about? Anyone seen that? You don't see usually. You know that's the problem I have.
Sir, why don't
Is
we
this?
use boost here? Sorry, contrast here. So then we can
Yeah.
easily identify the vessel.
You can. You can.
Can we use?
We can do and then it's be better. But but I don't know how many center use the contrast for the breast. Like I'm working in UAE, they don't use the contrast. I asked them. They
So
don't.
they do it for pelvic contouring, but why not?
No, we can. We should do for the breast as well. Same principle everywhere. Same principle, right? The principle is same for head and neck. It is very important because head and neck is that you need to know the vessels for lymph nodes. But then since PET scan come, that is also less important. So I would here turn around. The changes you see here may be because of the wire, right? Could be because of the wire. Okay. Now we did this. We draw one in here. Now we'll finish in few minutes. So what sometime I copy and paste as well. But because I'm taking big jumps, I'm not doing copy and paste. Because for big jumps, if you do copy and paste, it will not come. And I will do approximate and then it's okay for us. To later you just when you draw your own, then you do very nice one. Oh no, you have to click. We see another clip that may be homeostatic clip. That's how surgical note is important. So there is a wire you notice there's a wire for the breast marking, a rounded wire which tell you where the breast is, and that usually by the palpation. Okay, now I would not go that far because now we are coming down. So this is what they took as a wire place at the time when they do palpation and everything. So I take it as a breast. Oh, sorry. It's okay. I will accept it for the time being now. Okay, so this will be my last slice. Anyway, they put the wire, so therefore I'm taking it as a guide. If not, you see here the tissue coming, and you see here the breast fold is coming. This was the both double skin is coming, breast fold. Anyway, now we interpolate it. We see how it look like. It may look like ugly, by the way, because we have so many. You see how it look? It look like a duck or something, because we have this nose there, and then anyway, that's fine. So whenever I grow the volume interpolated, after that I definitely look a peak I give. Okay, now few tricks. So now GTV should not be, this is not the best volume we draw, but it's okay, we'll manage, just we want to learn. So what we want to do, always save, and then I want to boolean in the CTV and GTV to be under CTV. So CTV high or GTVP. GTVP apply to CTV. So GTV should not go outside the CTV. Okay, that's done. Now what I do to have a good breast, I would again save every time you do everything, just save. Then you do the cropping. We did the cropping. You know this technique. Just here will be body. Body is there. Okay, and then this one, and up to I do 5 millimeter. Okay. Sometimes if it is very close to skin, you can do 3 millimeter, and then I apply. Okay. So life is easy, and look at this here. Okay, that's the make life easy. And then PTV grow 5 millimeter. The important thing is PTV eval. So how many people know about more detail about PTV eval? PTV eval is what? Can anyone say? PTV eval. Okay. Then let's do that. Let's do it, because if I was not trying to planning to do the PTV, but I think let's do the PTV first. So can we draw the PTV first? You need to say okay. So let's do PTV. So if there is a PTV here, we can use that. We can just remove, clean it, and then okay, just don't do it now. Let's do another PTV. Then we'll see what was done. Okay, we'll compare. Any benefit coming or no? So PTV, I just type here PTV then. Okay, PTV high. Okay, so we take a PTV high and we give it a different color. Let's see what other beautiful color left. I came to this field because of the color, by the way. When I saw the color, I said, oh, this looks very beautiful, nice field. So I was attracted by the color. So let's do PTV now. Where is PTV? I did it purple color, and where is the PTV? It's come here. So last, oh, no, not even then. That one. PTV height should be yes. Okay, let's see if I'm missing. Yeah, yeah. But this PTV high is a different PTV high. We have a purple PTV high. Okay. Where is it? Find it. Lost. I don't know. Structure lost as well. Right there. 1015 is the one we can use. We can use that one. No problem. Let's. It doesn't matter. Is this one? Free one? Yes, yes. PTV val is there, by the way. No, I don't want to remove the past one. I don't want to. Let's do a new one. Something which is not used. Okay, let's do this one. Left atrium I'm using. Huh? You remember? Free? Okay, let's do PTV intermediate. PTV intermediate. Okay, and it's purple. I think it was the one which we did. Okay, now, so PTV, when we come to the PTV intermediate, whatever you name it, grow. So you took the CTV, CTV high, then you give how much margin? 0.5. Okay, good. 0.5, right? And oh no, it didn't go 1.5. First you use this one, then use 0.5. Is it typed correctly? 0.5? No? Can you type 0.5? Let me put my glasses because we're going too deep now. 0.5 only. And because it will be all equal, done? Okay, now what I will do, I just apply. Glasses is too much, no need. So we did that, okay? Now we have PTV intermediate. We will copy this, so this is step important to learn. You copy this PTV, which you grow 5 millimeter all around, right? You copy it, duplicate. See the word duplicate, you use it. So there is another structure will come. When we click duplicate, is coming or no? Not coming, I don't see. But usually I would do duplicate here. Even if it is not duplicate, no problem. No issues. We can do this any other structure which is free. Use that one. So we copy the PTV which we created. Now PTV is a setup error or internal organ movement. Technically you should not modify it, but we need to modify. Because the PTV going in the air, you will never get the coverage. And if they try to do the coverage for the dose distribution, you will give skin dose higher. Because in the air they have to pump up a lot of radiation. So then electron will come on the skin, will give a skin reaction. Okay? So we need to create an evaluation. So PTV eval is evaluation. So you copy PTV, then crop from Which structure? Skin, very good. 5 millimeter, like you did for CTV. We crop. Which is the other structure you'll crop for the? Okay. But pectoral is CTV. Answer, get it. That's it. So two things you will minus from. Okay, PTV 5 millimeter under the skin and lung. Okay. Now important part here for physicists, dosimetrists, and radiation oncologists. When they open the jaw, they open the jaw for PTV. Okay. But when you look into the DVHS, you look into PTV eval. Because if you ask PTV for them to give you 90-95%, be unfair to dosimetrists, honestly. We sometimes ask them. And then they say, doctor asked this, and how can, yeah, they complain actually. I went to one time Pakistan Aga Khan, and so they all complaining about physics, our physics. They said, there's something wrong. I asked physicists, they said, can you ask them to show you the volume what they give to me? They give this big volume, half of the body. And then they say, you save the heart. And heart dose, Dr. Abbas is not here, actually, it was his physicist. So they were saying, give the zero dose to heart. He said, how can zero? They have this kind of discussion. So anyway, now you know PTV valve. So PTV valve off lung. So your physicist or dosimeter will open the jaw for this because why? Setup error. Things can move, but still be in. But you don't need to burn the full dose there. The dosimeter should know the PTV valve dose you're looking at. Otherwise, you will do a bad plan, by the way. So you need to talk to your physicist. So that's PTV valve. PTV valve, you look into your coverage. Okay, clear so far here? Completely? Okay. Very important points, these one. So when you have this now, when you do the lymph node, I'm not drawing lymph node, but you saw the lymph node. I'll share you the atlas. It will take long time. We'll see if it is drawn already. So now CTV boost. Let's finish the boost. We didn't finish the boost, right? We just the CTV of the boost. Where is it, our CTV? CTV, which was GTV. So it was GTV-P we have. They have as well, but we have our own. We're different from the other people, right? This was CTV high the breast. Where the GTV gone? Now so many structure. GTV we did N. Okay, fine. Can you find? You help me. Pull your chair forward. GTVP, I think. Yeah, you're right. This is the GTVP. Yeah, this the one. Okay, green. Green, I think. This the one, I think. Green. Yeah, no, you're right. I find it. Yes, this the one. Now you need CTVP. Which one is empty? This red is empty?
It's not empty.
No, okay, give me the one which is empty. Yellow one, you can give me aortic valve, no problem. But just remember it. Otherwise, when you plan, then it will be aortic valve will be planned. Okay? Yeah, or boost. So when we are finishing the GTV, CTV, PTV of boost, we're doing boost volume and APBI volume. Same volume. Same. Just learn two things in your life. Don't have to learn too many things. Complicated thing you will not remember. So just two things. How to draw the breast, how to draw the GTV lumpectomy. Then if you know GTV lumpectomy, you can draw the boost or you can draw the APBI. Right? Okay. So which structure is this now which you knew? Is this one? Yes, okay. So now we create the CTV from this one, and this is important point here. Therefore, I bring you, and there is a sequence. So GTVP, now you find me. This one? Yes. Okay, good. And how much you give? 1 or 1.5 centimeter. I agree for both, but let's do 1 for now. Yes. Okay. Both will be okay. 1 to 1.5 is okay, but let's do 1 for now. Okay, you see how the margin is? Now, what is important step here? CTV going into the lung should not go. How would you deal with it? Okay, I did this. This is CTV underscore, right? Find me CTV underscore because I'm too far. Down? Above. Oh, okay, yeah, good. So this is here. Now body and not body here. Here you do CTV high. This is CTV high because this is the breast we draw, right? And then you do 0. Because anything which is out of the breast should be removed from this. Okay, that will solve you. See here. How easy. I take 5, 10, 15 minutes to draw the volume.
If the planner say patient coming tomorrow, I said just sit down here, bring a cup of tea for me and you, and we finish it in 5. Because of all these steps you learn, then it will be very quick. Now, all you need to do, breast PTV you've done already, PTV eval you've done. Now boost you would do PTV and PTV eval. Also, if it is going in lung, you will minus. Also, if it is going under the skin, it may not need to be minus, but I make my habit. Every single PTV I do the same, even there's no need, because if sometimes the CTV, GTV inside the breast, you will not minus anything. But I do for my practice, I do minus. So habit is I do GTV lumpectomy, then I do breast, first two structure. After that, now you can do up to you. PTV breast, CTV lumpectomy, the boost volume, PTV, then PTV boost volume, crop from the skin, crop from the lung for eval. All this done, it's easy for you. Now everything will be easier. Okay, so I use the tools and toys for that. And this will be now, you want to do how many things you can cover here. You can cover APBI treatment with this one. You can cover breast treatment with this one. Even if I don't need boost, I draw the structure. You know why? Because if therapist treating and setup is not good, I say focus on the CTV boost, right? And then they treat as a miss other place, no problem. Because my belief is in future we will not be treating those structures. Okay, but treat now. I'm not saying don't treat it now, but then if your therapist is in trouble, say them, okay, is the CTV cover, GTV cover? That's what I do on the phone, and they say yes. Then I review the offline later on, but then I have the answer. Okay. What I want to tell you here about PTV eval, we talk about. There was something I want to mention you here, because this one is not. So the PTV can go air, no problem. There was one thing I missed here. So when they plan, when it comes, then I will tell you. But when the guys plan, we talk about flash. When you treat, you do 3D. When you treat, you put yourself into the air, anterior border. Why you do that? Because you think there may be breast soiling. It should not be PTV, because you give them the PTV, you set up error. It may be the compensating for the breast soiling. So people were giving 1 centimeter, some give 2 centimeters, some give very open. This thing increases skin toxicity. So I don't give, because I have a paper. We did randomized trial in 180 patient, and we did not give flash. We call it flash, beyond the skin flash, and the other half we did, and we find skin toxicity very little. If there is no flash, outcome is same. So we're not missing, because as long as GTV, lumpectomy or tumor bed is included, you're not going to lose anything, even if you miss, right? Someday maybe soiling, take it out. So I did that study, so I don't give flash. But if you give flash, okay as well, you can give. I would not go more than 1 centimeter flash. If you give, I would not give. But the problem I saw, one of my therapists patient have underfold skin reaction. That is more common side skin reaction, because two skin is touching, electron vibration, it is moist, it is wet. Plus what he did not bring the MLC up to here. It was MRT plan. He just fold the MLC like this. This patient of mine suffer a lot of skin reaction in that area. So when you look into the plan, when I look into the plan, I look into the sagittal. If it is VMAT, I look into the sagittal and I click the play sign, and then I see where my MLCs are going. If MLC not blocking under the breast fold, this is a common mistake will happen. Then skin reaction will be higher. Okay. So anyway, you understand the flash concept. Anything which I missed? So yeah, lymph node drawing. Yes. Okay. Yes, it will take time. It will take time. I was trying to avoid, but I'll give you the tip. So see here, the important thing is that someone told me the 2 centimeter below the skin, right below the breast. Okay, not wrong. Now look at the PTV, where the PTV is. Okay, it came there, and plus you have to do treatment volume. This is PTV, treatment volume beyond that. So yes, I remember now what I want to look for. Something I want to tell you. When you want to do APBI, or when you want to do SIB boost, if the patient is not fit for that, don't do it. If you see that patient you want to do APBI, you told the patient, but it's coming on the skin and full dose, and now it's not good candidate. Tell patient, I'm sorry, during planning you're fine, and we do moderate hypofractionation. Sorry about that, or fast forward or whatever. Don't push for it. Okay, that you have to do. If patient is not eligible, do something else.
If the patient not eligible, SIB boost to sequential boost. None of these study inferior to other dose, right? All equal. You're trying to make patient life easy by less number of treatment, resource utilization, time, everything you're saving. Okay, but if it is not possible, don't do it. You don't have to push for it. Okay. Now here you did SIB. Now when you would not do SIB, and when you would not do partial breast. So I have that answer for you. How would I do that? So I go here, I go to the CTV high, right click, okay? Then I go properties. And in the property, I go to the structure. Okay, and I'll wait for where is the volume will come? In this one, will come here or no? Structure, it will come volume? Yeah, here, look. So how much is the volume of the breast? It doesn't look like it correct, but yes. That's very, it does not look like correct. Yeah, here it is, statistics with the structure, 574. Very small. Usually more than that. Okay. Okay, check from external view, no problem. Because it seems like 574 look like a smaller. So I think that's not the correct volume. So I'm told that, okay, 574 is coming. Okay, this patient breast is small, no problem. We accept it. Now what we do, next thing what we do, we check let's take it different. Now how I do assess, I tell you the principle. So what is the CTV boost? With our CTV boost, which we did. Okay, CTV underscore, this one, okay. Right click and go to measure volume. This one, okay. How much is it? Okay, 95. Now divide 95 by 574 and tell me what percentage is it coming. Yes, from 574. So 5, so this is 95. So 95 divide by, okay. Okay. Now this is important. Why I'm saying this? If your volume is more than 30% of the boost volume, start questioning APBI, start questioning concurrent boost. Concurrent boost have a very much advantage, because the DVHs are lower. It will go one time and then it treat everything. But when it start giving more than 30% of the CTV of the boost volume, start questioning. To be honest, I accepted even up to 50% sometime, but after 30%, I start looking into cautious. Okay, 40% you can accept, more easier. Above 40, think about, make your own cutoff. But the study says between 30 to 50%. But if you don't have good sophisticated planning and setup error and all this, I would keep myself to be 40% or under. Ideal is 30% or under. Allow, so first goal 30% under, second goal up to 40%. Okay? Clear? Yes. Okay, clear? Nobody will tell you this all. Not clear? I repeat. I stand up maybe and let's say, because these are important points. This will not be written in the book and you will not read in the article. So these are the practical tips when you are part of the study, because I was part of the study. So I was doing daily practice. So I learned from there. Otherwise I would not know. So when you draw the GTV lumpectomy cavity or the boost volume and you did the CTV over that, okay? That CTV volume you'll measure how much it is. And then you measure the CTV breast volume. Then CTV boost volume divided by CTV breast volume, calculate the percentage. Okay? If percentage is 30% or under, fantastic. Okay? If it is above, up to 40, accept. If it is above 40%, cancel SIB, cancel APBI. Do old style sequential or, okay? This is the point I want to make. Not every patient eligible, but also I see most are eligible. Look at this one. I'm not happy with seroma, it's a bigger seroma.
You know the way clip is? It would not be the tumor bed. I guarantee you, this is overestimation of tumor bed. If you talk to surgeon, where was the clip, which clip, homeostatic, which clip for the tumor bed, you will reduce this volume. But even with this bigger volume, and even the breast volume is smaller, which is 574, is not too big, what is coming up is 16% of the volume only. So it'd be hard to not to do it. But not to do it, when you look at, you will understand not to do this one. This is too big of a seroma. Okay? This point clear to everyone? Percentage calculation clear? All? Last line? Okay. Because you know, when I don't want to study, when I was in school, I failed actually in my school class. Those days I was sitting the last line. And then I was not paying any attention to teacher, but I got the bad result for me. He didn't, and I suffered. So anyway, this part, up to this part we come. Now the node, I think. Anything else left for the breast or the boost or? Yes, please.
But sir, why we are doing this percentage?
Percentage, if it is boost volume is too big compared to the breast, you are intensifying the dose in that area. Either you're intensifying as APPI, you're giving 6 gray per fraction, or you're giving SIB boost. SIB boost 48 gray per, so 48 means 3.2 gray per fraction. So when you're intensifying the dose, whenever you intensify the dose, or you do SBRT, like intense dose, always your volume should be within certain limits, right? Like when the brain, when you treat the SRS or SRT, you have a volume limit. If it go beyond that, you don't do that. You do whole brain or you do, right? Same apply here principle. If it is too big, do sequential boost, or don't do boost, or don't do APBI, do moderate hyperfractionate or standard dose. Okay? Now any other question? If you do, then more side effect will happen. Your patient will cry. We would have no problem, he will be okay, and the dosimetry will be okay, but patient will later cry. There was one study, 38.5 gray in 10 fraction BID dose. We did rapid trial. Rapid trial, I am co-author. The rapid trial, this is my most cited paper in the world. Like I have, alhamdulillah, more than 150% papers, but among those, the most referred paper mine is rapid trial. Your rapid trial was, imagine 38.5, 3.8 gray, 3.85 gray 2 times, 6 hours. When the gap we calculated, how we calculated gap? That how much between 2 fractions should be. How much is the time between 2 fractions? Everybody know in the world, right? Even the first year resident will know, 4 hours, 6 hours. How it come? So radiobiology calculation not always correct. When it go extreme, it fail. So they did calculation 38.5 in 10 BID treatment will be equal to 1525. Okay? And they said, okay, let's do it. So how we get to 6 hours, I just give you a little bit history. When we did the Petri dish test, we find to sublethal repair of normal tissue damage repair required 4 hours. So in the beginning, we were giving 4 hour gap. When we give 4 hours, we still find more toxicity. So we said radiobiologically 4 hours okay, but clinically we need 6 hours. So then we start giving 6 hours, right? And 6 hours the whole world knows. 6 hours for which dose? What dose per fraction? Convention, 1.8 to 2 gray per fraction. This is 3.8 gray. See, when I told you Florence study breast, 6 gray per fraction, they give alternate days. Right? Right? So this was the mistake. I was talking to them. But the guy is very stubborn, not listen to anyone. He said the 6 hours for every dose. Okay? So this patient, then one of my patients come, I don't forget. Very nice old lady. And I examine. When I touch, I find like a tennis ball sitting inside her breast. And I asked her, are you okay? She said, no problem. I said, but this is hard. It doesn't matter. Cancer is gone. Do you feel pain? No. She didn't have the pain. But there's a tennis ball sitting inside her breast. So this was too intense. Then other time I was doing a locum. A short time I go in Ireland. I keep my license. I go Ireland. I have a house and nationality, and Canada same. So I go 1 month to work every year, one place. So I go to work in Ireland. So Florence study, they were practicing. Okay, but what they didn't read, if you read Florence study, you'll be laughing as well with the word I'm saying to you. They wrote non-consecutive fraction. So they did not pay attention to it because they write alternate days fraction, right? Then we attention. Oh, it is alternate days. It is weekly. It is daily, right? But when we say non-consecutive, it's the same meaning, right? Because it's not the daily. Consecutive is daily. So they wrote non-consecutive, and Irish people missed it. And they were treating everyone with 5 fraction 30 gray. Not too bad, but then the lady changed as well to 5 fraction daily, but she did dose some changes. CTV different dose, PTV different dose, because PTV is on the normal structure. So then I asked, so I found about 10% of the patient complaining breast pain. I was thinking, why they complain? So then I go and check, and then I tell them, guys, they said, where it is written alternate days? I said, here is it written non-consecutive days. They said, oh my God, we didn't understood that. Okay, so poor patient will cry. We will be fine, but they will have the pain. It's a joke, don't take it. Ask the question. Any other question? Yes, please.
In patients with very small breasts, do you think it's still necessary to go all the way to the clavicle with a cranial extent, I mean?
Yeah, so that's this is anatomical boundary is a guideline. It is not a must. So it's a good question, because the anatomical boundary which RTOG use, some of the field experts object that. They say if we follow the vessels is good, but it's difficult to follow. So unfortunately, we don't have any other guideline. But I feel if the breast is small and if it is not reaching up to the medial end of the clavicle or below that, it may be overestimation of the volume and we may treat over volume. But unfortunately, we don't have any other better option or guideline that we can omit those.
I think
But
at least in the patients with dense breasts, probably it's safer to go a bit lower, like look at the gland.
yes,
Because you can see
we can. If we are treating only breast, that's also good to go lower, because there's a continuity of the vessels. You see the red comp atlas, they continue the supraclavian internal memory, and we are discontinuing them, but they're the same continuation. Okay, so here is the same thing. If you're treating only breast, yes, you have the room, but I tell you a counter argument to that. So, but when you bring the board, if you're doing the lymph node, then it need to be continued, because interpectoral lymph node we just talk about. So there's a drainage to the axilla, drainage to internal memory, but drainage infraclavicular vessels that goes to interpectoral nodes. So we need to continue. So if we are treating breast, I would continue at least either node or yes, we'll give you a chance, or at least the node volume I'll draw, or the breast volume with the node volume, but make it continue. Sorry, you want to say something?
And for more advanced breast, like deep-seated tumors, more advanced,
Yes.
do you take in the entire pectoral muscle, or do you just
Okay. So if it is depending on mastectomy or have seat, no problem. So if it is mastectomy patient, there is a controversy. Some people say go anterior to pectoralis muscle. It's still. Some people say take the up to the lung and rib intercostal muscle junction. But actually I go halfway. So there, and the other people say halfway. And I think Astro guideline was saying the halfway. So that is safe for mastectomy patient. For intact breast, till the time I don't know if I know that pectoralis muscle was invaded, I will not include pectoralis muscle. I go to the anterior border, unless we saw the clips of very posterior then. Just Dr. Kamal, please.
So the intrapectoral nodes.
Interpretary, we talk about that, rotor's node.
Yeah, so we are seeing the pectoralis minor and major, seeing the space, drawing it, going up, going up, going up. At one place, we don't see the space. I mean, it's
Right.
marked.
I don't include that when it is
So
only muscle.
where we will stop this?
When you don't see the tissue, space between them.
The black space is gone, so it's
Yes, it's gone. There I stop. So and as I mentioned that there are some limitation of RTOG atlas. If you use, you will miss the interpectoral node. And also RTOG included interpectoral node with the breast volume muscle volume. But I don't do that because node is node and the primary target is different. Yes, Dr. Kamal.
So another question is sometimes we see some patients that say 21 nodes was dissected and 20 was positive.
Yes.
So it's a heavy burden disease.
Yes.
So it is tempting that even it is operated, shall we cover that area? I mean,
Yes. Good question.
I mean, it's always a temptation.
Yes,
Because
yes, yes.
To me, I understand the principle principle is they have taken care of that dissected part. I am taking care of the undissected part. Whatever the situation
Right.
is, if I'm treating. But
Right.
when the number is 1 and when the number is 23, then I have a temptation. Shall
Yes,
I?
I have answer for this all. You know. It's good.
I know you have answered. That's why I asked.
Yes. So we discussed something. Have seat, please. Have seat. So first thing we discussed two hit, and I hear the two hit now. I did something which is my personal. I said, please don't quote outside the room. So two hit, I learned in my experience that if the tumor, gross tumor area, treated by two modality of treatment, because we have three modality: surgery, chemotherapy or hormone therapy, systemic treatment, and radiation. If two modality have used in the gross area, it's fine. If it is one modality used, then I bring the other modality as radiation. So for example, supraclav node, we give the example, and supraclav node only given chemotherapy, no surgery. I'll bring the boost dose, and I try to find the excuse and streak or whatever left, I will boost it. So this two-hit theory now for axilla, because axilla we know that if it is surgery happen, after surgery, if we give radiation, the risk of lymphedema increase. This is unique example what you said. It's not for every patient, but average Danish study, the risk of recurrence was 1% in axilla, in dissected axilla if you treat or not treat. But the risk of lymphedema raised from 15 to 30%. So now if 1% fail, that can be salvageable as well. I'm just theory making. So after dissected axilla, it will be the risk of failure in axilla is only 1%. So now that does not mean specifically this patient, because they took all the patient and they give this number, this magic number they come up. If you feel you want to do it, you can do it, but you have to think about that this patient is going to have more lymphedema. Also to remember, depending how you're treating. If you are treating tangential field, you are giving 80% of the radiation dose according to Encima analysis. And MA20, which the whole world follow for the node, I enroll one patient and never enroll again. You know why? Because it was very problematic study. So they give only 80% radiation to the node. So according to Encima analysis, if you do tangential field, you are treating axillary node. But things have changed now. I was talking to the people here. Try to draw the volume, even if it take more time, but it'll be very good learning, very good for patient. So if you do the volume and you do IMRT, then the story is different, because axilla will not get radiation. Now, for me, if you ask me, all past calculation of 15 to 30% raised is based on field-based treatment. Also, Danish study very old, when they said 1%, that's also that time, and they were doing tangential. So if I have this kind of burden disease, and if I'm doing IMRT, then I'll be careful, and I may think about. But in my practice, I don't do dissected axilla. I use the word undissected axilla I treat, or supraclav. Sorry, Dr. Kamalia.
So I'm sorry, I mean,
Yes.
maybe you have discussed about the axilla after neoadjuvant chemotherapy.
No, not specifically after neoadjuvant, because that's the B51, that's another discussion.
No.
Yes.
After neoadjuvant chemotherapy.
Okay.
So they have done the dissection, and you know that magic number of 10 is not working there.
Not a problem.
They are getting 5 or 4.
Yes, not a problem. I have answer for that too, yeah. So because sometime after chemotherapy there be atresia, lymph node happen. And actually I met with pathologists, I worked with them for a short time to learn. According to how they cut the slices, they can give you 9, they can make it 12 if you want. You know, they'll find another 3. So but the reassuring thing is, Danish study where all the axilla data we are quoting till today, that even one node positive we need to treat, that Danish study average number of lymph node was 6. 10 number is from MA20, the study which I don't like. I'm saying honestly, I did not enroll this. My name is not there in MA20 anywhere, because I enrolled one and said, bye-bye, I will never do it again. It was very difficult, you know, by wide tangent, you're treating heart, you're treating lung, you're giving 80% dose, doesn't make sense to me. All those things were there. So Danish study says if you have average 6 number, average, some will be less than 6, some will be more than 6. And now time is proving, by the way. When sentinel node studies are coming, it is proving knowing lymph node microscopic, not macroscopic, ultrasound based, clinical based negative. And when you do surgery and you find some node, microscopic node knowing can only give you 2 information. Treatment decision, even that is changing. Treatment decision to give chemo or not to give chemo, or radiation chest wall or not. and prognostic. How many patients will fail distant if node positive? Therapeutic value of lymph node is not there for microscopic lymph node. And we keep learning that. Because if you look at when we do the sentinel node biopsy, we analyze our patient in Canada, our center, 10% was false negative, but we're taking them negative and we're treating and the results are not too bad. And now if you do the chemotherapy study, for perimenopausal, they do chemo up to 3 node, but postmenopausal, even 3 node, they do the biological marker, and according to that, they make the decision. So I think it all makes sense if you put it together. It makes sense that axillary microscopic disease have the value to know what treatment we give them and what would be the prognosis. Therapeutic value to must target every microscopic disease may not be there. Okay, but let's give more time. These things will come up. We're talking today on the assumption basis. So, Dr. Kamal, you have something?
What about SNB after NSCT?
Yes, so after NSCT also this is now proving actually. Before we were fighting as radiation oncologists. How can 2 node positive you're not doing, and we were fighting. But the principle becomes same now, that if the patient upfront, before NSCT, you have gross disease or not, ultrasound based, clinical based, biopsy proven based, if it's only microscopic, would be taken care because chemotherapy will take care.
No, but what is happening, some of our colleagues are doing, it was proven by
Yeah.
biopsy or NSCT, it was a no. So there was a no.
But
Now,
how many node? How many node?
I mean, when
Yeah.
before chemotherapy, ultrasound, they said there are nodes, 1 or multiple nodes.
Okay.
And we did a core biopsy and proved. So for me, it's a node positive in class.
Yes.
So my principle was, whatever the scenario, you need to do LND because it was once it was plus, it's plus. But now they are telling no.
No, it's
So
changing.
we do a SNB, and
Change.
if SNB is negative, we are not going for any dissection.
No, we all were like, I was like you, we were like, we all were together, same.
But the problem comes on me
Yes.
that they have done a SNB
Okay.
and they have found it negative. They have not done the dissection. Now, is it our job to cover it or?
It is. It is our job because see the MROS trial, I will extrapolate here. And I would actually, to be honest, I was like your page was fighting with a surgeon. But one surgeon is very close to me when you come to Dubai or Abu Dhabi this next meeting, then you're not coming this meeting, isn't it? November. Yes. So what will happen that I will introduce you with the surgeon. I was having fight because she's like my sister. And then I have fight. I said, how come? Please do LND. He said, no, Nadeem, you guys are not understanding. Your radiotherapy mind is different. Come to operating room, look at the complication. You have such a beautiful thing, which is called radiotherapy. I'm pushing you, give radiotherapy. You want me to cut? Why you want me to cut the patient? So we have that discussion. In the end, she won. Now the data coming, I'm very carefully reading all this. And I'm finding that they are right. Less cut, more radiation. So if they don't take care of the node, and node was positive before, definitely I will treat axilla. And that would not give it. You know how much lymphedema risk? Only radiation is 5% risk lymphedema. With them, 15, 20, 30%.
So it will be like Amaros.
Like Amaros.
Where we are not dissecting axilla.
Yes.
But considering it's a very early stage, we
Yes.
are covering
All the lymph.
all the levels.
All the
level
level.
1 to 3 all.
Yes.
So this is this is the message, please, to my colleagues, that we should not confuse it. Amaros was something that we did SNB, and SNB was negative, but
No, SNB was one positive,
but
yes.
they didn't go for
Yes, axillary dissection and did radiation
the
into.
radiation we've given because it was early stage.
Yes, exactly.
Here we have given chemotherapy, which was proven to be node positive.
And it was advanced stage,
Advanced
possibly.
stage.
Yes.
But after neoadjuvant, there is SNB negative, but we cannot depend on this SNB only. There is no dissection, so that was the question, because surgeon has done their job. They have made their life easy, not doing the LND.
Yes. They don't want to
When they have
cut
not
much.
done the LND, it was not positive, so somebody need to take care of the axilla. We need to cover all the levels.
Right, exactly. This is a must. I know when Dr. Kamal is asking questions, not that he want to learn. He want you guys to listen to that. I know when
I'm learning.
his questions are there is some direction.
Dr. Nadeem,
But this is very important point.
Let me be very honest.
Yes.
I have been treating breast for so many years, but last time when you came in United,
Yes, yes,
I loved your word. I always try to pick one thing
yes,
from the whole session.
yes, yes,
So I picked out one word,
Yes.
undissected axilla. And
yes,
with
yes.
my
This is the
colleague
word I
Parvez,
keep in my mind. And it actually can be level 2 included, can be level 1, it can be level 3,
so
undissected
because
axilla,
now I don't
undissected.
count which level.
Yes.
Before I used to
Oh
tell
yeah, no, level is not an issue.
before I used to tell my juniors that it
Yes.
is dissected at level 2, let us take care of 3. I
Yes.
said no. Remember
Undissected,
Dr. Nadeem said,
undissected.
see the
Undissected.
seroma,
Surgical
from there you
seroma.
start.
Actually, what I ask my surgeon, wherever I work, it take me time, put the clip on the top
In
level.
Bangladesh, they don't love to put
They will not. But I think axilla surgery changes you can see.
So no, the
Yeah.
seroma is very much distinct. We can see the
Yes.
deviation of the anatomy.
Yes.
And I start from there and keep on going.
Yes, this is a must. By the way, this is a must because surgeon left for you to give radiation. And if you don't give radiation, good luck to patient, right? That's the challenge. The challenge is that end of the day, like we behave like father or mother for the patient. So, and before it was one physician base, now it's team base. So if surgeon does this, you need to do this. If surgeon does different, you do different. And this need to be coordinated. That's how MDT, peer review, all this come in there. And actually, by the way, I noticed that beyond MDT, your relation with the surgeon, your relation with therapist, your relation with physicist, you guys read each other's mind without talking. Now, whenever I work somewhere, beginning part with Rocky, because they said, oh, this guy is, what he's talking, this is nonsense. These things will happen, by the way. And you're telling your physicist who said, they're crazy. You're give big volume, heart should 0 dose, lung should not. That's Nadeem Parvez does. He's not here, therefore I can say that. He said to his physicist, give 0 heart dose. He said, how come? Not possible. He said, no, I want 0. So these things will happen in the beginning. Build a relation. If you're working with someone most of the time, build a relation. They read your mind. I'm absent from my work last 3 weeks, roaming around Vienna, everywhere. And my team is working well. The way they're working the way I want. When I go back and check, they do extremely well. They don't need me anymore. Because we read each other and then we learn from each other. Something I learned from therapists. Therapists, sometimes people underestimate therapists, but I learn. Because they're the one who's delivering. Whatever you did, artwork and beautiful plan and everything, if it is not delivered, useless, right? So they teach me something I'm amazed. They showed me how a linear accelerator can work like MR Linac. And there is something I'm working on it. I have 7 patients so far, 8th I done, 2 more than 10 I'll publish. So we can do intrafraction movement, motion, I'm talking about prostate, not the breast, for the prostate cases like MR Linac. So this was a therapist who told me there is something called trigger image. So trigger image, every 15 seconds, it can give you an MV image. And somehow if you make your target to be look at MV image, during entire radiation rotation, you're watching where your prostate gland is. Okay, so trigger image, I have no idea. This learned only, man about maybe one year ago, 1.5 years ago. So that was a therapist who told me about trigger image. And it's a revolutionary thing because you don't need to buy an MR Linac if you want to treat the prostate only by intrafraction movement assessment. So anyway, these are things that we learn from each other. So build your relation because all of us, end of the day, physicists, therapists, surgeon, we want to do good for patient. That's our main goal. There is some egos you cannot handle. Some people I cannot handle. I give up because they're very egoistic, and you say whatever, they thrash you down like you're nothing. You are radiotherapy? Okay, work for me like a physiotherapist. You are my assistant. You're working for me. I have problem with that because I either fight or I ask them to come equal level. But I'm noticing that the time passing, people mentality changing. We are getting better. Before was surgeon means you are very strong. I was surgeon. I started as neurosurgery. So I started and then I switched my field. So I know there is an ego there. In the work it is ego. I was worked in the army as an officer. There is an ego. When I have the uniform, I have different personality. I have to. And when I retired, when I leave the army, I don't know, I feel like my shoulders are light. I have some big pressure from me is gone from my over. So there are some ego come according to your character, your role, what you do, including all of us. That will happen. But try to find the middle ground somewhere with everyone. It would be impossible with some people, but it would be possible with many. That's possible. Any other question now? Lymph node, I can show you lymph node. And few level, yes, Dr.
Yeah,
Kumar.
sorry, maybe I will leaving. I want to tell the colleagues one thing, that I think the old time of tangent field was good because you knew that you are treating 80%. But for now, there was total responsibility is on us. You treat what you draw. You are not taking the risk of tangent will cover 80%. So
Yes.
today there was a presentation from a Japanese colleague, Dr. Makishima, who works with carbon ion particle therapy. So he was talking about precision radiotherapy, and I love his word. He said that if you draw the GTV, you have nothing to do, you draw the GTV. When you're drawing the CTV, every pixel you draw, you are taking a risk of irradiating something which may cause toxicity.
Right.
Again, every pixel you draw, you are taking a risk of missing some tumor and creating a chance of marginal recurrence. Because in head and neck, there is a study done, majority of the recurrence happened on the margin. So the problem is that what Dr. Nadeem is telling, due to this precision radiotherapy, surgeons are putting most of the ball now on our court. And we really need to cover the nodes very perfectly, because under the banner of IMRT and VMAN, we are not taking the so-called tangential beam. Anis will never put a tangential beam anymore. He will optimize the dose and that area will be spared. So we need to know what we are drawing. TPS doesn't know what is node.
Yes.
If I mark this is node, it will treat that node.
Yes.
So sometimes I feel that that was less stress when the tangent field was there. We put a high tangent, we cover it. We know everything is inside.
Yes.
But now we want to save the patient from lymphedema. Are we saving the patient's tumor from radiation? That is very
Yes.
important.
Yes. We discuss actually. There's the red comp atlas we did for proton. So we discussed that issue. That look at the drawing. Drawing is very different.
So when
Yeah.
Dr. Nadeem draws something, it seems it's very simple, very easy. But when I take my mouse in my hand, then you feel the challenge. So whenever you go to overseas, to a wonderful center like MD Anderson's, things are so nice. As if it is like seeing a movie, dreaming myself as the hero. But I'm not the hero, I'm just watching. But at this moment, during 3 hours, I become the hero, I'm doing it. So in MD Anderson, I feel like I'm the radiation oncologist. But when I come back to my center, nothing works like that. Mouse is not moving like that.
Here was also mouse was moving slow. We were complaining
So,
about it.
What I tell that this session is recorded, and this recorded session will be available in our website. So don't consider. I know you people are very sharp. You are much bright, 100 times bright than me, but not enough to learn everything in one session. So you
Yes.
need to go
No, I think
back
it
to
needed.
the video, what
Yeah.
Dr. Nadeem said, how he showed, again and again and again. And because I have seen the head of the department of Tata, JP Agarwal, opening the laptop and then drawing. I said, what you are doing, JP? Kamal, I need to check. So there is no harm in it.
Yes.
So he was telling, we need to be father and mother of the patient, something like that.
Yes.
So
Wait,
we
we
should
have
not
this.
do injustice to our patient. I am in favor of high-tech radiotherapy if I am ready.
Right.
If I'm
You-
not ready,
See, the Nadeem Abbasi came with me, but he left. He said, what are you going to teach? I said, breast contouring. He said, what in breast contouring? It's only how many hours? I said, 2-3 hours. We did in Riyadh 5 days on breast
Yeah, I know.
And I told the guys here that I'm missing many things. I'm not saying to you because I don't have time. Dr. Nadeem Abbasi said that why you routine 3 hour waste? Just put 2 lines and finish. This is done. So he come for it. I said, okay, in the end, this will be your talk. I'll give it to you. He said, just 2 lines. That's it. Don't waste so much time of everybody. So he come for that fun, but then he left now. He's not here.
Okay, please carry on.
Okay, thank you. So we go to now to the node. Okay, we have lots of time we consumed for this discussion. So node, I'll show you the main quickly one. So can we go back to the PPS again? So I can start talking by the time they're going to pull it up. So I start usually from the top. So top you follow cricoid cartilage. Where the cartilage stops, you start from there. When you draw the volume, there are both vessels, you know that in the medial. So there are three different group of people that how they draw the volume. So medial, lateral end of the volume, there is no issue. Anterior, posterior, no issue. Medial and the vessel, some people take the entire vessel into it. Some people take halfway cut the vessel. Some people take medial of the vessel. Now, when you have any one of you seen supraclavian failure, any one of you? No, I've had many times when I was a resident. Oh, those days, lots of recurrences, cobalt unit, not good treatment. So when you put finger here, behind clavicle, you feel where it is failed. It failed about after 1 to 2 centimeters from the medial end of the clavicle. Okay, so we don't need to go that far to the midline because CTV we learn from pattern of recurrence. We learn CTV where the GTV is seen later on. So you said, oh, I should have treated there because there will be microscopic disease. So for supraclav, when I put my finger, it is about this much, 1 centimeter at least, from the medial edge of the clavicle. And if you look into the vessel behind it, it will correspond to the lateral edge of the vessel. And that's the CTV. When you do PTV, I don't give PTV margin medial because people get esophageal toxicity because of that. So I give, so NRTOG, and I think one of the atlas says that medial don't grow margin, every other direction will grow margin. And any node minus from the lung, because don't forget it's prophylactic or elective nodal irradiation, where 80% of dose according to that trial, NSAPP trial, 80% dose is, sorry, MA20 trial, is enough. So if you miss some day, it's okay. So not to be too much hard on it. If you have a compromise between nodal coverage and the GTV lumpectomy, you compromise the node, which is prophylactic. You may or may not need it, and you need lower dose. But GTV lumpectomy means you'll be done. So continue that. Unless you have GTV node, then you would be focusing on that. Okay. So node we start from the. I will show you where the top slice. Then the transition part is that we make up somehow, and then we come to the lower one, which we discuss interprectoral and everything. You don't have any problem for that one. Okay, so let's go again to the top, like as we discussed. Now, if you want to have some problem here, that we can open the other volumes. Should we open another volume or no? Open another one. Just finish the breast one. That's fine. So yeah. So see the how the inter-observer variation come, which Dr. Kamal was mentioning. Because there was, I can tell you, there is a. So the note, the one volume you have done. Do it later. Okay, make it no problem. While you're doing that, I was thinking about the breast volume done before us. Can you open that one, or not? The one you bring for this patient.
Or I can create new structure.
New structure you code for the node. I was thinking the breast volume done already for this patient. Can we open that just for comparison?
Oh, okay.
Yes, yeah. Just click on. Okay, yeah, keep CTV1. Keep it. Okay, that's fine. I just want to go through 1 minute. So see, this was Dr. Kamal was saying that you know how you draw, it's a big important point. Because you see that the two different physicians draw very differently, right? So please, I will share you the atlases, and I really want you to not to stop here, because the workshop for the breast contouring was 4 days by IAEA in Riyadh, and I missed actually 5 days, no 4 days, 4 days. Thursday they're finishing. I missed 1 day with them to come here. But then I want you to learn because I compromised there. I lost my award. They said, oh, we have the award, we have this. So I left everything and said, I'm coming, I'm going Bangladesh. But the point is, there is inter-observer variability.
Okay, what are the way we can come off inter-observer variability? One option is auto-contouring. Auto-contouring, whether what I draw, what you draw, doesn't matter. Auto-contour is own different value. But we did not reach to auto-contouring that level yet, but we will. Prostate, I'm working very hard on it. You will see one day auto-contouring come from IAEA. You will see my name there as well. I'll be the co-author among all other people. They took the expert from the world. But now I'm keep pushing them. Do for the breast, because I'm not pushing for no reason, right? We have lots of inter-observer variability. But while we spend so much time in here, if you don't continue the practice with those atlases, it will fade away. And if you want to contact me, feel free. Whenever I can answer, I will answer. I don't not answer people. Sometimes I answer late or whatever. I'll answer if you have any question. Or you go to like Dr. Kamal or your seniors. But those papers you need to practice. So I need to make sure that you got it. Okay, let's go to the lymph node now. Lymph node, as I mentioned here. So I just take this aortic wall. Sorry, I was after the aortic wall. This is the first one. It's easy for her to know. So now see here the cartilage. You see the cartilage, right? We go down. You see cartilage. Yes. Still, I think almost gone here, right? Gone here. Agree? Okay. Let's bring this to where we will draw. Now, which one we are here? Abdomen one, right? Do you see very well in abdomen one? I don't see as much. Let's see if we can do any other contrast which make better. And you can play also contrast. Like you can just drag this way and let's see some preset. Abdomen view was street liver. To me, I think I can see better than abdomen at least. Huh? Liver. This one is liver. But sometimes things work different. Sometimes I do individual. But contrast is very important, by the way, because you can get MRI level of seeing a structure on the CT. Learn from a physicist. This is my physicist teach me. His name is Gino Filone. He got the best Italian award of the presidential award in his time, and he built 2 machines. So he's not and he's not easy guy, very difficult guy. Okay, and when you cannot see very well, make it big as you want. It doesn't matter. There's no harm. There's no charge for making it bigger. So now I told you that you can go from here as well, or you can take it all. Let's take it all for the best purpose. Okay, now what we were talking about, flat black tissue. Okay? Agree everybody about this one? Agree? You understand? See the muscle and with the muscle border. Okay, till when? See the vessel here? You can come here medial, by the way. You can come here. Or you can go there. Do you see the esophagus? Where esophagus? So I always protect the esophagus. No need to give esophagus radiation. Okay, then you come. Then some places you start difficulty. Yeah, up to here, not problem. I don't think any problem. Up to here, I think no problem. Now I will switch back again the contrast. Now I'll go back to abdomen because higher up it was good, but now it's not showing as good, right? Now it's better. For there, that was better. So play with contrast. It's free. You don't have to do any much work for this. Okay, now if I'm going down, if I did one vessel and the other vessel I took half and I draw this, make sense when I'm turning here? No bone, muscle. Agree? Now at some time point, you need to take the axillary vessel. When subclavian vessel we take it, right? Here is subclavian vessel, this the one. Okay, up to from here at subclavian level. But what I do, because PTV also will cover, but I do cheat a little bit. When I come here and I see this, I draw like this. Okay, you don't have to. Because you need to come to the, yes, and then you connect them. You can connect them. But because this is not the level you should draw. So if I draw, I don't connect it. Because PTV will come also. So come here, the vessel, here is the vessel. Okay, you see the vessel? When you subclavian vessel, now from here, you need to take. From here, you need to take all this. Level 3 node, level 2, I saw some drawing was very different. Okay, up to here. and depending on you're treating axilla or not, or undissected. If it is undissected, then I would do here. But if it is dissection issue, then I go out here. Okay. Then from then the transit will be, you will see transit. When transit come, I do interpolation, I don't draw, and then I make it sense. I do, because even if you draw here like this, in here you draw like this, they may not be able to cover it. It will not be covered. So no point. So I do where I don't know transit, I just draw above and below, interpolate, and then modify, make it look humanly, not on the bone, not only. So okay, here now very easy. But this in RTOG is missing, huh? This part is missing, which I'm drawing now. It's level 3. Okay, then we come level 2. This is level 2 behind. Then I'm coming interpectoral. Okay, got it? So only level 1 I'm not covering here because that's beyond this one. I'm not covering. I'm expecting this is dissected axilla. Okay, then so level 3, level 2, interpectoral, and level 1 is from here. So I expect it's, see, dissected, right? It is. I expect it to be dissected. But if not, then we can come to that. Okay, then for how far you will continue this way. So I show you top. I show you here. How far you continue? Continue, continue, here. So what I do, the RTUG say you can draw breast volume like this. But I don't draw that. I just node is node. So what I draw like here. This is behind the breast. Okay, this is the way. And where I see the highest level of dissection, it may be here. Suppose if this is the highest level, I will stop here. Done, finish. But look, 2-hit theory didn't get here, right? The surgeon did the surgery or not? Imagine your mind. It did. I will go down. Even though none of the guideline will say that. They will stop after the breast volume. They will leave these notes. I will not leave because my 2-hit is not done. My 2-hit done because surgeon stop. If he did the surgery, he would have stopped at level 1 here. Okay, so I will take till the time which Dr. Kamal asked. Look, now you don't see any gap, right? And therefore I grow the PTV before I draw the node, because PTV is covering, right? Here is covering. Now from here, and then when I draw here, the PTV of node will cover here. Okay, so what I do, I start drawing from, for example, this is covered, right? Agree? Covered, 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 not covering here, not covering. But if you do the PTV to higher up, it will cover. And this is very thin rim here. But here I will draw. I will draw. Either I draw it in the breast, as RTUG said, or I draw as a separate volume. But I will draw. I will not miss because it's not 2-hit for me yet. Okay, then I draw this one. Okay, now the only axilla I need to show you. When we are treating axilla, so I don't do dissected part. By the way, here I go too far. It's not I do. Because you know what we said, word undissected axilla. So this is dissected axilla to me, I'm assuming. Suppose it's not the case. Okay, now let's play with the axillary node when you have to draw the node. Come here. Now you need to see on this one. Now you can actually interpolate. By the way, we interpolated everything and it was okay so far. Even we draw only few slices, it comes good. So now suppose I'm treating axilla as well. So how would I do different? So I come here, I will do different this way. Aortic wall it is still. It has to be aortic wall and here. Then I will go here. Okay, I'm taking level 1. And even if you go up to here is okay. But if you remember at Radcom, they go all the fat tissue. But Dr. Kamal already heard this morning, I missed that talk. That time I just was in the, I think I landed in flight and I don't know where I am that time, because it was the early morning. I lost my mind that time. So here is the one, if you go here, see, very obvious. We're not missing. Actually what I do generally, I come up to the muscle, but I don't dig in here. I don't dig in here. There's no recurrence I've seen there. But I may come up to the muscle. Okay. So this is the difference. Okay, and then here I would, if it is not dissected axilla, I will come here, I will come here, and I cover. Because this is not no vessels here, no node. Okay, then when it come finish, this is finished now. So what? How would I do axilla now? Until when? We'll talk about that. Okay, like this. You don't have to go that much anterior here. Okay, this will be the axilla now on down. Okay, you see here, even you see surgical changes in axilla. So it is so easy to know when it is not dissected, right? This will be your volume. This is your volume. And look, I was missing from the top this one because the surgeon even don't dissect there because that's not come into the definition for them. Now, when will you stop drawing? Anyone knows? Yes, tell me. Okay, I'll come down from here. You tell me when to stop. Sorry, I come back here. This is my volume. Now, continue. Sorry, just let continue. Continue. You tell me, I'll stop. Stop here? Okay. Why you said that? Because you know that the landmark is when pectoral is inserted onto the bone. Yes, so you see that? So it is almost inserted, like difficult. This one is inserted. I will take one more that slice, but it's okay, you know, or you don't take, doesn't matter. But I won't go beyond that. Agree? Now this is done as well. Should we interpolate and see how it look like? It will look like crazy, by the way. Let's draw first this slice, which is last we think. Okay, let's take this one as last. Okay, and now interpolation. You see how crazy it look like. But anyway, look, no, it's not too bad, but only here we miss. You know why we miss? Because if you draw one volume and you don't continue it full, then it will take half of the volume. So before interpolation, I usually check. But it look not so bad. See, this one you will remove, you will come up to here. You may not do this one because I already told you that this is all generous from me. So you will remove this one, this one, this one, even this one you can remove. Okay, but then you will make it here up to here, and then you will make it like this, right? You'll make it like this, and then also here like this, because those slices I did not extend. If I would have extended, it will be better. Okay, let's see axilla. Axilla come very nice. Okay, now any question up to here?